All right, so guys, very warm welcome to the very first session of rapid revision series for foreign medical graduate exam going students. So guys, we know that due to unavoidable circumstances, your exam that was supposed to happen in the first week of December has been postponed, and now it is on 20th January 2023. But that's absolutely okay. So let's take it in the healthier way कि हमारे पास थोड़ा और समय आ गया है. हमें पता है कि हमारी तैयारी बहुत अच्छे से चल रही थी फर्स्ट वीक ऑफ दिसंबर को माइंड में रखकर, लेकिन क्योंकि एग्जाम अब थोड़ा सा पोस्टपोन हो चुका है तो क्यों ना हम इस समय को एक अच्छे तरीके से यूटिलाइज करें. सो द आइडिया विल बी टू यूटिलाइज दिस टाइम टू द फुलेस्ट, राइट? सो व्हाट आई हैव डन इज आई हैव picked up 15 hot topics, and what I am going to do is I am going to discuss those 15 questions with respect to the most commonly asked points with respect to those 15 topics. So that is my agenda for today. This is a very short, crisp and concise session, and this will be live. So in case you have got any queries live, you can always and always ask me. Even after the session, if you have got any queries, you can anytime WhatsApp me, you can reach to me on Facebook, on Insta. I am available everywhere for you guys. So guys, without wasting any more time, let's start with the session. Hi Sachin, I hope you are doing good. Good evening. So to start up with the session, very first thought, so that is the number one skill in life is not giving up. Please don't give up. I know you have been working so hard since a long time, but it's all about not giving up. Second, never say never, because limits like fears are often just illusions, right? So with this, let's start up with the very first question. Hi Nafreen, hi Baljot, I hope all of you guys are doing good. So to start up with the very first question, guys, so this is the first question. In viral epidemic keratoconjunctivitis, characteristically there is usually, so there are four options: copious purulent discharge, copious mucopurulent discharge, excessive watery lacrimation, mucoid ropey white discharge. So guys, as I have always told you in the classes, that just by the way of getting to know about discharge, you can actually reach up to the answer. So the answer to this question is, guys, I am waiting for you to answer. Okay, great. So the answer to this question is, there will be excessive watery lacrimation. So this is the answer to this question, but let's just discuss few important points in and around this very disease. First and foremost, epidemic keratoconjunctivitis. So guys, epidemic keratoconjunctivitis, it is caused by which virus? Guys, it is caused by adenovirus. Your MCQ number 1 has been asked multiple number of times. Adenovirus. It is also known as, this epidemic keratoconjunctivitis is also known as pink eye. The other name of this is eye flu. The third name of this is Madras eye. This is your MCQ number 2. So I have given you 2 MCQs so far. Now can you see small dot. What are these dots? These dots are nothing but subepithelial infiltrates. Guys, this is subepithelial infiltrates. So these subepithelial infiltrates are seen in epidemic keratoconjunctivitis. Please remember, these subepithelial infiltrates can also be seen in acute hemorrhagic conjunctivitis if there is corneal involvement, right? Subepithelial infiltrates. Another important MCQ I am going to give you. Fourth, that in epidemic keratoconjunctivitis, there is preauricular lymph node swelling. There is preauricular lymph node swelling. I am writing it here. Preauricular lymph node swelling will be there, right? Dear Tane, ropey discharge will be typically seen in a disease which is known as spring catarrh. Other name is vernal keratoconjunctivitis. Is it okay? Now, if there is purulent discharge, you will think about bacterial conjunctivitis. If there is mucoid discharge, you will think about allergic conjunctivitis. If there is mucopurulent discharge, you will think about what? Trachoma. If there is watery discharge, you will think about viral conjunctivitis. These are the 4 type of discharges based on which you can identify the possible etiology of the conjunctivitis. Is it fine? I hope you guys got it. Great. So now I have given you 4 quick MCQs here plus some information about discharges and of course the answer to this question. Great, Tane, great. So moving over to our next question. Second question, express implant is made up of. So what is express implant? Guys, express implant is a form of a MIGS. What is MIGS? So MIGS is minimally invasive glaucoma surgery. So minimally invasive glaucoma surgery is a form of a surgery in which there is minimal invasion, minimal cutting of the tissue. So in this, we go from inside of the eye and we implant this particular thing which is express implant in the trabecular meshwork such that one end of this implant lies into the anterior chamber and other end of this implant lies into the Schlemm's canal. So basically, which structure has been bypassed? It is the trabecular meshwork. So express implant bypasses which structure? Trabecular meshwork. So you know na what is the pathway of flow of aqueous humor. So it is released from MCQ number 1, pars plicata region of the ciliary body. And what is the rate of the formation of aqueous humor? It is 2.3 microliter per minute. Second MCQ. Third MCQ, how it exits the eye. So it exits the eye from the anterior chamber via trabecular meshwork. It goes into canal of Schlemm. So if you implant this device into the trabecular meshwork with one end into the anterior chamber, another end into the canal of Schlemm, so the trabecular meshwork is bypassed now, isn't it? So this express implant is a trabecular meshwork bypass implant, and there is another implant that also bypasses the trabecular meshwork. The name of that implant is eye stent. Now the examiner wants to know what is the material of which this express implant is made up of. So guys, the answer is anyone the answer is, so I have got one answer from Tane so far. It is silicone. Anyone? Guys, the answer to this question is stainless steel. Good try, Tane. So the answer to this question is stainless steel express implant. But you will say, okay sir, you told us about another implant which is eye stent. So what is the material of which eye stent is made up of? Simple to remember. T for eye, T end alphabet of the eye stent, and T for titanium. So eye stent is made up of titanium, but this express implant last alphabet is S. S for stainless steel. SS, stainless steel. I hope you will be able to remember this. So express implant is made up of stainless steel while eye stent is made up of titanium. Is it understandable? And how much IUP does this implant decreases? This express implant decreases IUP by approximately 20%. So that is another potential MCQ for you guys. Is it understandable? And what is MIGS? MIGS is minimally invasive glaucoma surgery. Minimally invasive glaucoma surgery. Done. Now let's move over to the third question. Okay, so here comes the question. So a 12-year-old boy receiving long-term treatment for spring catarrh developed defective vision in both eyes. The likely cause is, guys, first I am going to give you quick MCQs on this topic, then I am going to tell you the answer. In that window period, let's see how many of you can answer this question. So of course the disease that we are talking of is nothing but vernal keratoconjunctivitis. Vernal keratoconjunctivitis, the other name of vernal keratoconjunctivitis is spring catarrh. 2 MCQs. Third, although the name of this disease is spring catarrh, but it is more common in summers. This disease is more common in summers. It is more common in males. Which males? Which are teenagers. Every single line that I am telling you is a MCQ. Either it has been asked previously or it is a potential MCQ. So I want you to pick up your pen and paper and keep writing, keep writing, keep writing. So males, teenagers, it is a bilateral condition. Bilateral condition. And what you can see here, what are these? Can anyone tell me what are these, guys? What are these? What are these? Yes, yes, you already know the answer. I am glad. I am going to tell you why this is the answer, but please let me know what are these. These are the large papillae. What are these papillae known as? These are cobblestone papillae. Cobble. Yes, great Mohit, ग्रेट आदिल, राहुल, ऑसम, नफरीन, कार्तिकेय, अरे बहुत यार आप लोगों को सब कुछ आता है. कॉबलस्टोन पेपिली. So these are cobblestone papillae. Now what happens is, because this disease is happening in children who are teenagers, so they will go to the doctor and the doctor will prescribe, a good doctor will prescribe an antihistaminic drug. So the drug of choice which is preferred in this disease is olopatadine. Olopatadine is a new generation antihistaminic, or you can also prescribe sodium chromoglycate, which is mast cell stabilizer, right? This will be prescribed to the patient if he goes to the doctor. But we are living in a country where the patients have more trust in the chemist than in a doctor. So the patient will go to the chemist and would say, भैया भैया मेरे बेटे की ना आंख में खारिश हो रही है, कुछ दवाई दे दो. And the chemist will pick up the magical medication from its बहुत बड़ा सा डब्बा and would say, ये सिर्फ 20 रुपए की मेडिसिन है, just use it and your child's itching will be gone forever. But what are the constituents of that medicine? The constituents is, number one is antibiotic. We know this is an allergic condition, so no role of antibiotic, which is not required by the child, right? Another important constituent is steroid. That steroid is like a two-edged sword. Of course, it will decrease the itching of the patient, but it can lead to development of two very important disease. One, it can lead to the development of glaucoma, and two, it can lead to the development of cataract. Now you know, if we are talking of steroid induced cataract, which is drug induced cataract, what is the most common form of drug induced cataract? Guys, the most common form of drug induced cataract is, it is posterior subcapsular cataract, and hence the answer here. But I want to step it up. I want to step up the game. As per that, now if you will use steroids in the topical form, most commonly it will lead to glaucoma, and if you use steroids in the oral form, most commonly it will lead to cataract. But I am not saying that only topical form will lead to glaucoma and only oral form will lead to cataract. No, because the steroids can cause both glaucoma and cataract, but topically most commonly is glaucoma with respect to cataract. I hope you got my point, right? I'm not writing because writing will take time. I want to make this video very crisp and concise for all of you, है ना? Yes, Adil, very good. Sangama, too good. Tane, Adil, and yes, chemist will give refreshed tears. Yes, refreshed tears will also be given, but along with that, any good antibiotic and steroid combination will be given by the chemist, is Ciplox, DX or Dexaviga, something like this. I hope it is clear, right? So the answer to this question is posterior subcapsular cataract. So I have given you 5-6 good MCQs. And another important thing, somebody mentioned it here. Do you know what is Maxwell-Lyon sign? Guys, Maxwell-Lyon sign is the thick, stingy, ropey discharge which is seen in vernal keratoconjunctivitis, and this discharge consists of eosinophils. So Maxwell-Lyon sign is seen in vernal keratoconjunctivitis. Maxwell. I am going to write it here because the name is a little tricky. So Maxwell lion sign. I am writing it here. Maxwell. You can write it down if you want to. Maxwell lion sign. This is a thick, stingy, ropey discharge which consists of eosinophils. And this vernal keratoconjunctivitis is, I am giving you an important update. It is type 1 plus type 4 hypersensitivity reaction. Now, if this is not in the options, then which option would you select? If this is not in the option, you will mark type 1. And if type 1 is not in the option, which one would you select? Type 4. So guys, the best pick is type 1 and type 4 hypersensitivity. If this is not in the option, go for type 1. If that is also not in the option, go for type 4. But the third most important option is type 4. But the most important option to be picked is type 1 and type 4 collectively, right? Okay, with this, let's move over to the next question. Next important topic, in fact. Okay, which of the following is not a cycloplegic? First, we need to understand, what do you understand by cycloplegia? Cyclo word is used for ciliary muscles or ciliary body, and the muscles are present in the ciliary body. So ciliary muscles. Arey wah, you all are answering beautifully. Plegia means paralysis. Now you need to understand, all of these 4 drugs are mydriatic agents, है ना? All of these 4 drugs are mydriatic agents. Now please understand, cycloplegia means paralysis of the ciliary muscles. Now the muscles which will cause the drugs which will cause cycloplegia will be the ones which will be parasympatholytic. Parasympatholytic means you need to understand that pupil constricts and it relaxes. So sphincter pupillae is the muscle that constricts the pupil. Dilator pupillae is the muscle that relaxes the pupil. So sphincter pupillae and dilator pupillae, both these muscles are in tug of war with each other. ये दोनों लड़ रही हैं, खींच रही हैं एक दूसरे को अपनी तरफ, है ना? So as a result, the pupil remains in a position which is around 3 to 4 mm in diameter, because the sphincter pupillae are trying to constrict the pupil, dilator pupillae are trying to dilate the pupil. Is it understandable? And you also know that parasympathetic action is sphincter pupillae and sympathetic action is dilator pupillae. Now if you will paralyze the parasympathetic action, so what it is going to do? The sympathetic system will overpower the paralytic parasympathetic system. As a result, the pupil will dilate. This is one thing of how you can dilate the pupil. Another is, you don't do anything to the parasympathetic system. You just stimulate the sympathetic system. So if you are giving extra stimulus to the sympathetic system, so sympathetic system will automatically overpower upon parasympathetic system. So one way of dilating the pupil is you paralyze the parasympathetic system. Another way of dilating the pupil is you stimulate the sympathetic system. Is it understandable? Now the examiner wants to know which of the following is not a cycloplegic. That means, of course, all these 4 drugs dilate the pupil, but which drug doesn't dilate the pupil by paralyzing the parasympathetic system? So the answer to this question is, you already know, all of you have answered it beautifully. I am so proud of all of you. So this is phenylephrine, because this is which drug? This is, boys and girls, this is sympathomimetic. Sympathomimetic, right? Sympathomimetic. Now I am going to give you 3-4 extra MCQs. Now atropine, what do you understand by atropine? Of course, atropine is a cycloplegic. And what is the duration of action of atropine? So duration of action of atropine is 10 to 14 days. Your MCQ number 1, important MCQ. What is the duration of action of homatropine? Duration of action of homatropine is 2 to 3 days. What is the duration of action of cyclopentolate? It is 1 day. So I have given you 3 important MCQs, and as all of you are very well saying it, so guys, if you want to have a cycloplegic effect in a child, you prefer giving atropine. What is the dose of atropine? Atropine is given in the form of 1% eye ointment. 1% eye ointment. So you will give 1% eye ointment if you want to have an effect of atropine. And why do we prefer atropine in children? Because the tone of the ciliary muscles in children is too strong, so we need the strongest acting mydriatic agent, and atropine is the strongest acting mydriatic agent. Is it understandable? Yes, very good, Nafreen, very good. Yes. Now, one last important point I want to tell you here is, what is the drug of choice in anterior uveitis? Of course, this question is out of the box, but the MCQ has been asked many times. So, drug of choice in anterior uveitis is which drug? You will give a mydriatic agent. So mydriatic agent is given along with topical steroid. But if the question comes which is the drug of choice and in one option there is steroid, another option there is mydriatic agent, then you will select the topical steroid. Is it understandable? So topical steroids are drug of choice in anterior uveitis, and they are given along with the mydriatic agent. Why? Because anterior uveitis, there is inflammation of the iris and pars plicata region of the ciliary body. Because there is inflammation of the pars plicata region of ciliary body, there will be inflammation of the ciliary muscles, and when there be inflammation of the ciliary muscles due to spasm, there will be pain. So you will give rest to the ciliary muscles. You will alleviate the pain, not alleviate. You will alleviate the pain by giving rest to the ciliary muscles. So that is why in anterior uveitis you will give topical steroids in conjunction with mydriatic agents. I hope it is clear. So this was your next important MCQ, which has been asked many times in your previous foreign medical graduate and examinations. Done? Okay. Hi Govinda. Namaste. Okay, great. Now moving on to our next question. So fundus of a young patient shows pigment along retinal vessels, waxy exudates over retina and pale disc. And the diagnosis is, I know you already know the diagnosis, but let's discuss few important things around this disease. So guys, this is forming the important triad. So there is a triad which is seen in this disease, and that triad is, there is pale waxy disc, there is attenuation of the retinal vessels. Attenuation means decrease in the caliber of the retinal vessels. Can you see the vessels are so thin, they are thread like, है ना? So that means attenuation. So arteriovenous attenuation, number one. Then pale waxy disc, and you can see this bony spicule pigmentation which are present at the mid periphery. Guys, this typical triad is seen in retinitis pigmentosa. Very good. All of you have got this correct. Very good Nidhi, very good Rahul, very good Mohit, everyone. Too good, too good. So the answer is retinitis pigmentosa, number one. Now important thing on which the question usually comes, the important thing is, most commonly this disease is sporadic. Most commonly this disease is sporadic. But if the disease is hereditary in nature, then most commonly it is autosomal dominant. I am just saying this disease can be sporadic, it can be hereditary. If it is sporadic, of course that will be most common. If it is hereditary, out of hereditary, autosomal dominant will be most common. So it can be autosomal dominant, there can be autosomal recessive, and there can be X-linked dominant. These three types of inheritance patterns are seen, out of which the most common are autosomal dominant types. Is it understandable? Very good Nidhi. Very good, Nandini. You got it correct. Great. So this is another important point. Next important point is what is the pathogenesis of retinitis pigmentosa? Retinitis pigmentosa में होता क्या है? सिंपल सा फंडा है. एक बार एक लाइन आप समझ जाओगे तो you'll be able to answer the next important question. So in retinitis pigmentosa there is apoptosis. There is apoptosis of rods followed by cones. Apoptosis of rods followed by cones. Now you have got this concept. Now my next question to you will be, what is the earliest feature of retinitis pigmentosa? I am sure you are going to tell me. So what is the earliest feature of retinitis pigmentosa? Retinitis pigmentosa का earliest feature क्या होगा? बता सकते हो? बताइए, I am waiting. So earliest feature of absolutely correct, Nandini. Great. Nidhi, great. So because rods are getting apoptosed, so of course what will happen? There will be increase in dark adaptation time and eventually there will be night blindness. So there will be night blindness and eventually even the cones will get involved. Eventually the patient will go blind. So earliest feature will be night blindness, or you can say increase in dark adaptation time, DAT. Is it understandable? So that is an important question which has been asked before. And which important investigation you will go on for in retinitis pigmentosa? It is ERG. So ERG is electroretinogram. Yes, Mohit, very good. Rahul, yes, very good, very good. So ERG is electroretinogram that you will go on for. So there are three waves that you see in ERG, and those waves are A wave, B wave, C wave, and A wave is formed by rods and cones. B wave is via Muller cells, and C wave is via pigment epithelium. So these things you have to remember. Is it understandable? So rods and cones, Muller cells, and pigment epithelium. Done? Okay. Now moving over to the next question. Great. So Fleischer ring. So Fleischer ring is found in. So guys, simple question, clear cut answer. Fleischer ring. So Fleischer ring is actually the iron deposition ring. Which is seen in epithelium, right? And it is seen in which condition? So it is seen in keratoconus, right? So this is seen in keratoconus. Can you see this small ring? Can you see this ring, brownish ring? So this is seen in keratoconus. Now what is keratoconus? Keratoconus is when the cornea becomes cone shaped. So there is thinning of the cornea and cornea becomes cone shaped. But please understand, as Tane has very importantly pointed that out, that don't confuse this Fleischer's ring with that of the KF ring. So KF ring is Kayser-Fleischer ring. It is actually the deposition of copper in Descemet's membrane of cornea. Please understand. So Fleischer ring is deposition of iron in the epithelium of cornea, but KF ring is the deposition of copper in the Descemet's layer of the, or Descemet's membrane of the cornea. Don't confuse these two things, hai na? Okay, great Prince. Very good, Nidhi. Yes, of course. So these are two important questions associated with this. And of course, in keratoconus, what you are going to see? You are going to see different signs. So there is Munson sign, there is Caesar reflex, there is window reflex, there is oil globule या oil drop reflex. So there are different reflexes that you are going to see. You will also see the striations, you call it as Vogt stri. I'm not writing because as I told you in the beginning, I want to make this discussion very crisp and concise. You can always revisit the notes and check that out. So Vogt stri are there. Vogt stri are due to tearing up of the Descemet's membrane due to thinning of the cornea, due to which there be corneal edema, and there will also be corneal hydrops. Hydrops means edema of the cornea. So these are 5-6 important points that you see in keratoconus. Yes, great. Rizzuti sign, very good. Rizzuti sign is a arrow shot sign that you see on the nasal side. Great, great. Chalo. Next is the treatment of choice for the other eye in angle closure glaucoma. So guys, I have purposefully included this question. है ना? Now in this image, can you see that there is anterior chamber which is so shallow? Can you see? This is actually the Von Herrick method of assessment of the depth of the anterior chamber. So Von Herrick states that the anterior chamber depth should be at least of that of the thickness of the cornea, and here you can see the anterior chamber depth is so much of decreased here, है ना? So what is the treatment of choice for the other eye in angle closure glaucoma? So I am waiting for your answers. Can you answer? Can you answer? Mohit, oil drop reflex you will see on distant direct ophthalmoscopy in keratoconus. When you will shine a light from a distance of 25 centimeter into the patient's eye who is having keratoconus, so you will see a small oil like globule appearance in the center. So that is oil drop or oil globule reflex. I am talking of oil drop or oil globule reflex, right? Okay. And don't confuse that oil globule which is also seen in galactosemic cataract. Don't confuse with that, है ना? Okay. So here the treatment of choice for the other eye in angle closure glaucoma is, we are talking of the other eye. If we are talking of other eye, the answer is straightforward. So here the answer is, most of you have answered it correct. It is YAG laser iridotomy. So why do you do YAG laser iridotomy? If you are going to make hole in the iris, you are going to stabilize the pressure in the posterior chamber and anterior chamber, and it will decrease the chances of precipitation of the attack of acute congestive glaucoma. Is it understandable? So that is why you go for YAG laser iridotomy, number one. Second, why I have mentioned the other eye? Guys, suppose the patient has come to you with acute congestive glaucoma. The patient has had an attack of acute congestive glaucoma. What will happen in acute congestive glaucoma? There will be sudden rise of the IOP. Due to sudden rise of the IOP, there will be sudden tearing of the Descemet's membrane. Due to sudden tearing of the Descemet membrane, there will be sudden edema in the cornea. And when there will be sudden edema of the cornea, so cornea will become hazy, isn't it? Now, can you actually perform laser iridotomy in a hazy cornea? No, na. So the only option you are left on with is to go for surgical peripheral iridectomy. What you are going to do, you will first lower down the raised intraocular pressure because the patient has recently had the attack of acute congestive glaucoma. Once the IOP has been lowered, now you would say, sir, how we are going to lower down the IOP? So you will give intravenous mannitol. You generally give intravenous mannitol. So that will lower down the intraocular pressure. When the intraocular pressure will be lowered down, then you will give an incision, take out the part of the iris, and you will cut it and you will put it back, and then you will seal the incision. Is it understandable? You call this as peripheral surgical iridectomy. है ना? But if one eye has got an attack, there are chances of the attack in the other eye as well. So the better thing to do is you just go for ND-YAG laser iridotomy. So that is a prophylactic treatment. But the therapeutic treatment in the eye with acute congestive glaucoma is surgical peripheral iridectomy. Prince Davis, we generally give mannitol because the onset of the action is very quick. So it starts acting in as less as 20 minutes. mannitol. So that is why we prefer this. है ना? Acetazolamide can also be given, but it will take some time. Na? You need to decrease the IOP, because if the IOP is prolonged for the long duration of time, then it can actually lead to damage of the optic nerve head. Fine. Great. Very good, Nidhi. Very good. Very good. Well done. Okay. Now, moving on to the next question. Earliest visual rehabilitation occurs with. Guys, it is simple. So, you know the size of the incision of various surgeries. So, you know extracapsular cataract extraction. What is the size of the incision? It is 10 to 12 millimeter. What is the size of incision in small incision cataract extraction? It is 5 to 6 millimeter. What about intracapsular? It is not preferred nowadays. Intracapsular cataract extraction is when you completely take out the lens along with the capsule. It is not done. It is done only in condition in which there is subluxation or dislocation of the lens, right? Now, what about phacoemulsification? Guys, the length of incision in phacoemulsification is your previous year question, 2.8 to 3.2 millimeter. So, of course, more is the length, more is the downtime, more will be the surgical induced astigmatism. You call it as SIA, S-I-A. So, less is the length of incision, better will be the downtime. So, less will be the downtime. So, of course, earliest visual rehabilitation is phacoemulsification. अब हमारे पास पेशेंट आते हैं, बोल रहे डॉक्टर साहब हम ऑपरेशन तो करवा लें, लेकिन उसमें कितना समय घर तक रहना पड़ेगा. लेकिन फेकोएमल्सिफिकेशन अगर करवाते हो तो जस्ट 3 से 4 दिन आप घर पे रहो, उसके बाद यू कैन फॉलो अप विद योर रूटीन ऑफिस वर्क और वॉट एवर यू डू. बट इफ यू गो फॉर एक्स्ट्रा कैप्सुलर कैटरेक्ट एक्सट्रैक्शन और SICS, स्मॉल इंसिजन कैटरेक्ट एक्सट्रैक्शन, you generally ask the patient to stay at home for 2 to 3 weeks, right? So early recovery and less astigmatism in phaco, as Dr. Nidhi has rightly pointed out. Very good, great. Now moving on to the next question. Fibrovascular proliferation in retinopathy of prematurity. Which stage is there? Guys, there are mainly how many stages? There are 5 stages in the retinopathy of prematurity. So first stage is, what is the first stage? It is the demarcated line. Demarcated line between avascular and vascular retina. Second stage is this line will get converted into ridge. So there is ridge. Third stage is there will be fibrovascular proliferation. Can you see the small vessels? These are small vessels, na? Which are coming from the vascular retina to avascular. Now my next question, why there is fibrovascular proliferation, my dear boys and girls? Because there is secretion of the magical chemical, and the name of that magical chemical is VEGF, vascular endothelial growth factor, that will incite the formation of new vessels. You call those new vessels are neovascularization. Is it understandable? And next stage is, you call it as subtotal retinal detachment. Subtotal retinal detachment. Now fifth stage is total retinal detachment. So these are the 5 stages of retinopathy of prematurity. Now subtotal retinal detachment is also divided into 2 stages. One is, which is A, you call it as 4A, which is not involving the macula. Then we have got 4B, which is involving the macula. Is it understandable? Quickly repeat. Quickly repeat. So stage 1, demarcation line. Stage 2, ridge. Stage 3, fibrovascular proliferation. Stage 4, A and B. A is not involving macula, B is involving macula. And fifth is total retinal detachment. Is it understandable? So these are very, very important things. Now another MCQ in regards to retinopathy of prematurity. That important MCQ is, what is the most common etiology of retinopathy of prematurity? As the name suggests, it is prematurity. Prematurity, number 1. Then we have got supplemental oxygen. First is prematurity. If this is not in the option, you will write supplemental oxygen therapy. Supplemental oxygen therapy. And third is very low birth weight. And fourth is smoking. Now don't ask, sir, maternal smoking or child smoking? Bhai, intrauterine में child cannot smoke, so of course it will be maternal smoking. At one of the centers where I was taking the class, I said, okay, the fourth important etiology is smoking, and one student asked, sir, maternal smoking or child smoking? I said the child is still intrauterine, so it cannot be the child smoking, it is maternal smoking. So these are four important etiological features. Great. Let's move over to the next question. Okay, Smita, the cutoff of LBW for ROP is 2000 grams. It is 2000 grams. Is it understandable? Right. Okay, now what is the Stocker's line? So Stocker's line is seen in guys, what is this? This is pterygium. Now what is Stocker's line? Stocker's line is again the iron deposition line on the epithelium of the cornea. But again, don't confuse the Stocker's line with that of the Fleischer's ring. Both are iron deposition lines in the corneal epithelium, but Fleischer ring is seen at the base of keratoconus, at the base of cone of keratoconus, while this Stocker's line is seen anterior to the head of the pterygium. Is it understandable? Head or cap of the pterygium. So the answer is clear cut. So here it is pterygium. Pterygium is the answer here. Great. Chalo, next question. We are just about to finish this quick discussion. So which is not found in papilledema? So papilledema is, okay, can you tell me what is the difference between papilledema and disc edema? Very important, but still very conceptual. Can you tell me? What is the difference between papilledema and disc edema? Most of you might think both are same, है ना? Adil, great, you are, yes, very good. See, simple answer, papilledema is bilateral disc edema, while disc edema is simply unilateral disc edema. Why bilateral? Because the cause is central, raised intracranial pressure. When there will be raised intracranial pressure, it will put upon both the optic nerves. There will be stasis of the exoplasmic outflow of both the optic nerves, leading to the collection of the fluid at the optic nerve head of both the eyes. You call it as papilledema. Great. Chalo. Now, what are the features of papilledema? What can you see in this diagram? So one is, can you see the peripapillary hemorrhages? So the peripapillary hemorrhages are seen in papilledema. One, of course, it is not given in the option, but we are discussing the topic as such, na? So I need to tell you that. So of course, peripapillary hemorrhages. Can you see that the margins are very blurred? The margins of the optic nerve head are not defined, they are blurred. So the margins are blurred or non-defined margins. Second important point. But this is also given, so this is the right one, blurred margins of the disc. Third is, can you see that there is some sort of champagne cork appearance of the disc? The disc appears a little protruded anteriorly. So this is the champagne cork appearance of the disc. So third option is again down. Now we are left with A and D. What are Patton's lines? So whenever there is stasis of the exoplasmic outflow on the optic nerve head, so what happens is this fluid, it starts to travel along the nerve fiber layer. When it travels along the nerve fiber layer, so there is appearance of the fine lines on the surface of the retina. You call it as Patton lines. So the answer here is blurred vision. So the answer here is blurred vision. Blurred vision, please understand that in papilledema, the vision remains as such till late. I am not saying that the patient will never have loss of vision. Of course, if the patient is going to land up in secondary optic atrophy is an atrophy in which there is disc edema, which follows disc edema, you call that as secondary optic atrophy. Of course, then there will be loss of vision. Tab loss of vision hoga, but in early stages there is no blurring of the vision. There is no loss of vision. So that is the answer here. Is it understandable? Yes, yes, Smita, it is the late sign. Of course, when there will be peripapillary hemorrhages and too much collection of fluid at the optic nerve head, so there will be champagne cork appearance. Is it understandable? Is it understandable? Yes, Vikas. Of course, the chronic stage will be followed by the acute stage, na? So it will be late stage. Yes, Prithvi, one can be bilateral enlargement of the blind spot. There can be, what is blind spot? Guys, don't confuse blind spot with that of the optic nerve head. Optic nerve head is the physical thing that you see, while blind spot is what you see in the perimetry, visual field analysis, right? I hope you already know. है ना? Okay. Smita, Patton's line is nothing. You call it as Prithvi has mentioned, it is peripapillary chorioretinal fold. So these are stretch lines. You simply say retinal stretch lines. So when the fluid will pass along the retinal nerve fiber, so there are retinal nerve fiber, na, hai na? So there will be edema in between the retinal nerve fibers, and you will see fine lines on the retina. You call these lines as Patton's lines. Is it understandable, Smita? I hope it is. Okay. Now, commonest symptom of congenital glaucoma. Guys, very important. What is the triad of congenital glaucoma? So there is an important triad of congenital glaucoma. So this is lacrimation. I am telling you about the triad of congenital glaucoma. So it is lacrimation, it is photophobia, and there is blepharospasm. This is important triad of congenital glaucoma. Number one. Second, there is typical appearance of the eye. You call it as boophthalmos. What are boophthalmos? They are ox eyes. Ox eyes, boophthalmos. Right? So, commonest symptom of congenital glaucoma is there will be lacrimation. So, you call it as watering of the eyes. This is the earliest symptom you see in a patient with congenital glaucoma. Is it understandable? Now, as someone has written blue eyes, so what happens is, due to raised intraocular pressure, there is tearing up of the Descemet's membrane. Can you see these small lines? What are these lines? These are known as Hobbs striae. Hobbs striae. Don't confuse Hobbs striae of congenital glaucoma with that of the Vogt striae of keratoconus. Vogt striae are the striations or tears in the Descemet's membrane due to thinning of the cornea in keratoconus, while Hobbs striae are due to tearing of the Descemet's membrane due to raised intraocular pressure in congenital glaucoma. Is it understandable? Yes, because photophobia is most troublesome. That is why there is reflex blepharospasm. What is blepharospasm? Blepharospasm is forcefully closing of the eyes. So this is blepharospasm. Of course, why there is blepharospasm? Because there is photophobia. Good. Is it understandable? Okay, yes, in fourth pick, there is Hobbs striae. And boophthalmos, I have already told you. What is the treatment of choice in congenital glaucoma? This question has been asked. The treatment of choice is goniotomy. Goniotomy is the treatment of choices in congenital glaucoma. Chalo, now moving on to the next question. All are features of optic nerve disease except, all are features of optic nerve disease except. So whenever there is involvement of the optic nerve disease, let's say optic neuritis. Optic neuritis, what will happen? Of course, there is inflammation of the optic nerve head, na? So you will say that the patient has optic neuritis, and there will be what? There will be disc edema. Don't say that the patient will have papilledema. There will be disc edema, right? So disc edema will be there, है ना? Now what will happen to the pupil? There will be afferent pupillary defect. Why? Because the optic nerve forms the afferent of the pupillary light reflex. When you will shine the light into the patient's affected eye, when you will shine the light into the patient's affected eye, the optic nerve is damaged. So the optic nerve will not be able to take the light reflex to the pretectal nucleus of the midbrain, and as a result there will be absence of the efferent reflex, which will be via oculomotor nerve, and as a result the pupil will remain dilated. So there will be afferent pupillary defect. Pupillary defect will be there, and it is due to defect in the afferent pathway, so you call it as afferent pupillary defect. है ना? Is it understandable? Next is sudden loss of vision. Of course, there will be sudden loss of vision. Bhai, optic nerve is getting involved, so there will be sudden loss of vision. And in optic neuritis, do you know that optic nerve sheath, the optic nerve sheath lies in continuity with that of the superior rectus muscle. So when the patient's eye is inflamed, optic nerve is inflamed, and when you will ask the patient to elevate the eyeball, especially in cases of retrobulbar neuritis, so what will happen? The patient will have pain. So pain on movement of eyeball, specifically on elevating the eyeball. Is it understandable? Now what about headache and vomiting? So my dear friends, headache and vomiting is not associated with optic nerve disease. Don't say, sir, headache and vomiting will be associated with raised intracranial pressure. Raised intracranial pressure will lead to papilledema. My dear friends, papilledema is not the primary optic nerve disease. The papilledema is due to raised intracranial pressure, and that can be due to intracranial tumor, or IC as well, intracranial space occupying lesion. That is not a primary disease of the optic nerve. Here the examiner has played a trick upon you that all are features of optic nerve disease. So we have to restrict ourselves to the optic nerve disease. So headache and vomiting will not be a feature. Headache and vomiting will be seen in raised intracranial pressure, that is in papilledema. And which form of vomiting is there? I am sure you all know. Which form of vomiting will be there? It will be projectile vomiting. Projectile vomiting. Nidhi, I told that the optic nerve sheath, which is dura, it is in contact with the sheath of the superior rectus muscle, and when the patient will elevate the eyeball, so there will be contraction of the superior rectus muscle, and it will also put a stretch on the already inflamed optic nerve, especially in retrobulbar neuritis, because papillitis is the inflammation of the optic nerve head. Retrobulbar neuritis is the inflammation of the retrobulbar part of the optic nerve, and as a result there will be more pain. So that is why pain on movement of the eyeball, specifically on elevating the eyeball. I hope you have understood. Yes, Smita, thank you. I hope, Nidhi, you have understood. Yes, Nandini, Marcus gun pupil or RAPD, relative afferent pupillary defect. If you have ever attended my class, so I generally show videos of all the cases that I discuss in my class, and I have shown to you a case of RAPD in my class. है ना? Okay, my pleasure, Nidhi. All right, so we are just on the verge of ending. So 2-3 more questions to go. Earliest ophthalmoscopic sign of diabetic retinopathy. So what is the earliest ophthalmoscopic sign? So guys, as I always tell in the classes, that retina, complete retina relies on the single liner concepts. So I am going to tell you one important thing. Based on that, you will know all the features of diabetic retinopathy, and that one important thing is that increased blood glucose is toxic to parasites. That's it. Increased blood sugar is toxic to parasites. And what happens is, in the retina, so the endothelial cells are supported by parasites such that parasite to endothelial cell ratio is 1:1. That means one parasite is holding one endothelium from behind. So it is not allowing endothelium to go anywhere. Now, because increased blood sugar is toxic to parasites, so this P:E ratio becomes from 1:1 to 1:3. That means now one parasite is holding 3 endothelial cells. Now you tell me, if you want to hold 1% from back, will it be easier for you? Or if you want to hold 3 persons together from their backs, will that be easier for you? Of course, you will be able to hold 1% from a back quite easily now. So when you will try to hold 3%, you may not be able to hold it. As a result, what will be the earliest feature? Those 3% would move far from you. So similarly, when there is movement of the endothelial cells far from each other, it will lead to development of one very important sign. You call it as earliest sign in diabetic retinopathy, and as Dr. Nidhi has rightly pointed, this will be microaneurysms. Is it understandable? So there are endothelial cells. So these are endothelial cells. I am making it for better understanding for all of you. So each endothelium cell is surrounded by one parasite. So one parasite is holding the endothelial cell. So when there is damage to the parasite, so one parasite will now hold 3 endothelial cells. So of course it will not be able to hold 3 endothelial cells. As a result, there will be microaneurysms. Yes. So the answer to this question is microaneurysms. And next important point, in NPDR, non-proliferative diabetic retinopathy, there will be microaneurysms, there will be soft exudates, there will be hard exudates, there will be soft exudates, there will be hard exudates, but there will be typical absence of proliferation. There will be no proliferation. That is why you call it as non-proliferative. Now, no proliferation means there will be no neovascularization. Please understand that neovascularization is seen only in proliferative diabetic retinopathy. Is it understandable? Is it understandable? Kartike, I would not be able to show you microaneurysm because the image is kind of small. If I'll exit the PPT mode, the class will get disrupted. So I am going to share my contact number in the end. You just WhatsApp me in the end. I am going to show you, I am going to message you the image of microaneurysm. Don't worry of that. Don't worry. Yes, Nidhi, you are absolutely correct here. Okay, great. Now moving on to the last question of today's discussion. So uncrossed diplopia is seen in, guys, this you require a little bit understanding of the concept. So why there is diplopia? So there are two things mainly. So one is crossed diplopia, another is uncrossed diplopia. Suppose the patient has esotropia. Now guys, I want your 100% attention diverted towards me because this is one important concept that I am going to tell you. So esotropia. So what happens in esotropia is the eyeball is turned inwards. Now if the object is lying in the front, so left eye is taking the fixation, so my left macula will be stimulated, right? But in the right eye, ideally if both eyes are taking the fixation, both eyes are aligned to each other, both maculas will be stimulated. But the right eye is not facing towards the object. Due to deviation in the right eye, this eye is turned inwards. When this eye will turn inwards, the macula will not remain at the center. Macula will go outwards, and in front of the object there comes to lie the nasal part of the retina. Is it understandable? When the nasal part of the retina comes to lie in front of the eye, but you know that nasal part of the retina actually identifies the temporal visual field. It is conditioned to see the temporal visual field because eyeball is not like a flat television, it is like a curved screen. Similarly, the temporal part of the retina is facing on the nasal side, so it interprets the field on the nasal side. Similarly, the superior part of the retina interprets the inferior visual field, and inferior part of the retina interprets the superior visual field. You already know it. Now if there is esotropia, that means now the nasal part of the retina is being stimulated. When the nasal part of the retina is being stimulated and nasal part of the retina is conditioned to interpret the objects on the temporal side, so it is going to send the signals to the brain that okay, this object is lying on the temporal side, when actually this object is lying in front of the eye. So there will be doubling of the image because of course both maculas are not receiving the image, so there will not be any fusion of the images. So left eye is seeing a separate image due to stimulation of the macula, right eye is seeing a separate image due to stimulation of the nasal part of the retina. So the patient will have a double vision of the same object, and the image provided by the deviated eye will be diverted into the temporal field because the nasal retina of that deviated eye is being stimulated. Is it understandable? Is it understandable? Now let's take another example. Suppose the patient has exotropia. So exotropia is the eyeball has moved outwards. Now when the eyeball has moved outwards, the macula has moved inwards. So that means now the temporal retina is in front of the object of interest. So when the object light is coming from front, the left macula is being stimulated while the right macula is not being stimulated because the eyeball has turned outwards. So right eye's macula is not being stimulated. Right eye's temporal retina is being stimulated. By my dear boys and girls, the temporal retina is conditioned to interpret the image on the nasal side. As a result, there will be doubling of the image. Because there is doubling of the image, there will be one real object, another false object, the second image, the double image, and it will be shown on the opposite side to the patient. So in the first case, esotropia, the image was on the same side of the involved eyeball, so you call it as uncrossed diplopia. While in other case, the exotropia, the image was on opposite side of the involved eye, so you call it as crossed diplopia. So now the answer is uncrossed diplopia is seen in, it is esotropia, while crossed diplopia is seen in exotropia. I hope you have understood this little concept. Trust me, this little concept is going to help you cracking one of the most difficult questions in ophthalmology, especially of the squint topic. Is it understandable? So guys, these were few important topics that I thought that we would discuss, and based on that, thank you very much for spending 1 full hour with me. I actually loved your attitude. You guys were so participating, and thank you for always being there. And this is the beauty of live classes, my dear friends. If the same class is presented to you in, say, recorded session, you may not feel that, that push to watch it. But since it is happening live, I am interacting with you, I am answering you, I am, solving some other doubts of you. So this is the thing that actually puts fuel to the process of learning. So this is the beauty of live classes. You can either attend it live on the app, or you can, best is gold standard classroom teaching. Best is if there is a DAMS center near your city, you should definitely come. And जितना मजा अभी हमने करे ना, उससे 100 times better मजा हम क्लासरूम में बैठ के करते हैं. जो स्टूडेंट्स यहाँ प्रेजेंट है, जिन्होंने मेरी क्लास लगाई या हमारी सारी डैम्स की फैकल्टीज की क्लास लगाई है, दे कैन एक्चुअली टेल यू हाउ मच एंगेजिंग, how beautiful, how much interacting those face-to-face classes are. But if you are sort of away, if you are in periphery, if you cannot come to attend the face-to-face classroom classes, then you can always go for live classes on NEETPG app. But as I always say to my students, if you have got the option of attending the live class on NEETPG app or a recorded class on NEETPG app, I would suggest you to attend it live classes. Only if due to undue circumstances you are not able to attend the live class on NEETPG app, only then you go on for the recorded classes. But the best is to attend the live classes. That actually makes the class really interactive, and that actually helps you to learn in a better way, right? So with this, I will take your leave. Thank you very much, and you can always reach me in case of any queries, any doubts from today's discussion or any topic in ophthalmology. You can always reach to me. I have given you my WhatsApp number as well. You can message me, and I'll be as quickly as possible to respond to all of you. Thank you very much. Thank you for all the love and respect. Thank you. Bye bye. Take care.